spinal manipulation and neurometabolite changes in the central nervous system. Yet again, we have a research publication evaluating changes in the central nervous system in relation to spinal manipulation. There are, though, several distinctions. This study follows patients over a longer period of time than most studies, and instead of using a functional MRI approach of using a bold signal to detect vascular increases in specific areas of the brain, this study evaluates specific neurometabolites in specific areas of the brain. The title is The Effect of Spinal Manipulation on Brain Metabolites in Chronic Nonspecific Low Back Pain Patients, a randomized clinical trial published in the Irish Journal of Medical Science in November 2019. The purpose was to study changes in brain metabolism after spinal manipulation in patients with chronic nonspecific low back pain using proton magnetic resonance spectroscopy. This is a novel outcome measure, unlike the standard measure of functional MRI bold signal. Proton magnetic resonance spectroscopy, or HMRS, is used to detect and quantify certain biochemical compounds, including creatine, choline, glutamate, and N-acetylaspartate. Some suggested functions of individual neurometabolites are: for N-acetylaspartate, or NAA, the metabolite reflects the density of neurons. Its reduction indicates the loss of neuronal function. The choline metabolite represents the health of neuron membranes, and glutamate, the main excitatory neurotransmitter of the brain, binds to both ionotropic and metabotropic receptors that play an important role in all brain function, including pain. The researchers state that for patients with nonspecific chronic low back pain, after physical activity, quote, blood flow increases in regions associated with the pain matrix, including the somatosensory cortex, insula, and frontal cortex. Moreover, in nonspecific low back pain patients, compared with healthy individuals, neurochemical metabolites decrease in the dorsolateral prefrontal cortex, the thalamus, and the orbitofrontal cortex, unquote. And that, quote, studies have shown that chronic low back pain causes central sensitization, and patients with chronic low back pain are hypersensitive to painful stimuli due to neuroplastic changes, unquote. So let's look at the study design. This was a small study with 25 patients randomly assigned to either spinal manipulative therapy or sham manipulation. There were 10 in the SMT group and 15 in the sham. The sham treatment was simply positioning the patient without thrust. Patients were evaluated at baseline and 5 weeks after treatment for both pain and disability and neurometabolic changes using the following outcome measures: a numerical pain scale, the Oswestry Disability Index, and the HMRS activity. The inclusion criteria were patients with nonspecific chronic low back pain aged 20 to 50 with a pain intensity ranging from 3 to 7 on an NRS, and those who were not treated within the last 3 months. The results? The changes in pain for the SMT group was a decrease from 6.2 to 2.6, whereas for the sham it decreased from 5.33 to 4.53. The minimal clinically important difference for pain on the NRS is 2, which was met by the SMT group but not the sham group. And for changes in disability, for the SMT group, an initial score of 30 decreased to 14, but for the sham, the initial score of 31 only decreased to about 30. The minimal clinically important change for the Oswestry is 10%, and this was met by the SMT group, but not the sham group. And for changes in the neurometabolites after treatment, NAA in the thalamus, insula, dorsolateral prefrontal cortex regions, as well as choline in the thalamus, insula, and somatosensory cortex regions had increased significantly in the treatment group compared with the sham group. There was a significant increase in NAA in the thalamus, anterior cingulate cortex, and the somatosensory cortex regions, along with the choline metabolite in the thalamus and somatosensory cortex regions after treatment in the treatment group, compared with the baseline measures. Also, there was a significant increase in glutamate levels in the thalamus. There was no significant difference in brain metabolites at baseline and after treatment in the sham group. So a very common mistake in interpreting the meaning of the designation significant is the following. In a scientific study, if the words significantly different or significant increases or decreases is used, unless specified as clinically significant, it means statistically significant, which means that the changes seen are statistically likely to be real and not due to chance. This is calculated and demonstrated by significant p-values and a 95% confidence interval. And what that means is that there is statistical likelihood that the results seen and the changes observed are 95% of the time real and only 5% of the time due to chance. So it has nothing to do with meaning that there is a clinically significant effect, only that the results are statistically likely to be real and not due to chance. And in fact, we have no idea what a clinically significant change or level would be in this study for any of the metabolites. We have no match to a normal to indicate that the change is meaningful. There are certainly some strengths. They were that they measured changes in pain patients, unlike other studies. They used a sham treatment, and they measured the results over a longer period than usual, at 5 weeks. And they compared changes in the NRS and ODI with what appeared to be associated neurometabolite changes. Let's speak to the confusion readers often have between association or cause. Here's a commonly used example. It's known that smoking is a cause of lung cancer. However, if you look at the statistics, coffee drinking is also associated. We know that coffee does not cause lung cancer, but is associated with smoking, which does. Why does this matter? The flow of logic. There are two possible explanations for the observed changes in many CNS studies demonstrating changes after spinal manipulation. The first is that spinal manipulation changes brain function, which then decreases pain. However, the other possibility is that manipulation decreases pain, which then changes CNS activity. And why is that important? Because if the latter is true, that spinal manipulation decreases pain, which changes CNS function, then logically anything that decreases pain will have the same effect on brain function. And in fact, there are many studies and systematic reviews that show this change for acupuncture, sham acupuncture, massage, and reflexology. So what we don't know at this point is the clinical significance of the changes. Does the amount of change represent a return to normal activity and amount of neurometabolites? And we still don't know whether the pain decreases change the metabolites or vice versa. And one last concern is if you read this article, you'll notice many typos and grammatical errors. This calls into question whether there was a true peer review.